So good evening, ladies and gentlemen in the room, and good evening, ladies and gentlemen, wherever you are in the World Wide Web. And welcome to the William Harvey Research Institute at Queen Mary University of London for this Gus Born lecture. So Gus was one of the founding fathers of the William Harvey Research Institute, along with some of you in the audience here and others who joined later. And Gus, as you all know, it's the reason you're here, was a wonderful human and an amazing character. So I was very delighted when Kerry gave us the permission to have this Gus Born lecture, which I hope to make a regular feature of in the future. Gus was a wonderful friend to all of us at the university here and the Institute. I remember very well in our 20th anniversary in 2006, I asked Gus to speak about his life in science. And he phoned me up every Sunday for a year, at exactly the time I was trying to sit down and have my Sunday lunch. I'd kept me on the phone for an hour telling me, "Oh no, Mark, this is not a very good idea. I don't want to talk about my life. It's not very interesting. I'll just talk about platelet aggregometers, if that's okay." And I said, "No, trust me, Gus, people will be really interested." And this went on right up until the day before he gave his lecture. And he rang me up and I thought, oh no, he's going to tell me he's not going to do it. And actually what he said is, "Hello, Mark. You know, I've been really worried about this lecture." "Yes, Gus. Actually, it turns out my life's quite interesting, really." And then after we held a festival for him around his 90th birthday, he came to me one day, sought an appointment, and he came in and he said, "Mark, now I'm 90, would you mind if I didn't come in quite as often?" And I said, of course, William Harvey adopts the Hotel California principle, which for those of you who cannot remember the Eagles from the 1970s, a popular music combo, the fundamental thing about the William Harvey is you can check out, but you can never leave. So with that, I'm going to hand over to my colleague and friend, Steve Watson from Birmingham, and he's going to introduce Beverley. Thank you, Steve.
Thank you very much. Well, I have the great pleasure of introducing Beverley to you today, but what I'm going to do just beforehand is also say just a few personal reflections on Gus. It's fair to say that I met Gus towards the end of his research career. I put it in that way because he'd probably retired 20 years before, but he was still very, very active and excited. And his boyish enthusiasm, even though he was in his late 80s, was really quite remarkable. So I asked whether he would give a lecture in Birmingham, and then later he gave a lecture to the Platelet, UK Platelet Group at a meeting in Cardiff where he came on his own all the way from London to give this lecture in his early 90s. And I remember those lectures and will always remember them. Some very simple slides, not very many, but my word, some really profound thoughts and ideas. And it was truly inspirational to listen to him then. And he was still talking about the new ways forward and his new ideas. He was just an enthusiastic person in such a way. But he also spent that time with the younger, early career researchers. So I feel absolutely privileged to have met him and to have known him. I'm really pleased that this lecture celebration of 100 years since Gus was born is happening, and it's rightfully happening in the William Harvey Institute. But in fact, this is the second Gus Born lecture that we've had, because the Platelet Society, which is, I've got a banner on the right-hand side, which only started 3 years ago, and it brought together two societies, the Platelet Charity as it then was, and the UK Platelet Meetings, started as a new society to really further platelet research, both for patients and in terms of research itself. And in that very first meeting in Cambridge, we had a Gus Born lecture. And I know that Platelet Society has helped to organise this lecture, and indeed will make this recording available on the website, and as well over 100 registrants from across the globe. And if they wish to put any questions in through the Q&A, I shall either ask yourselves or the people on the web for questions at the end. So now it's my pleasure to introduce Beverley to you. Beverley is truly an inspirational speaker and truly internationally renowned for her contributions to thrombosis, both in terms of public awareness and in terms of the leading nature of her research. Many of you may already know Beverley, and you may not even realise that. For the last 18 months, Beverley has been one of the leading figures because of COVID and the thrombosis associated with that, and in the last 6 months, because of the very, very rare thrombosis associated with the Oxford AZ vaccine, Beverley is one of the first to identify patients and indeed help change government policy on the vaccination. Beverley has worked with the World Health Organization with the NICE guidelines in terms of patients who have COVID and in terms of thrombotic management. Beverley has also started the Thrombosis UK Charity. It started in a different name in 2006, but if you're not aware of this charity, it really raises awareness on venous thrombosis, and I would recommend that you look at the website. It's truly remarkable what that does. But it's not only there where Beverley's contributions have made. She also was the chair for the World Thrombosis Day, which took place in October, working with the International Society of Thrombosis and Hemostasis. And for these many contributions in terms of awareness, she was appointed an OBE in the Queen's Honours List in 2019. But I also stress that Beverley is a leading researcher, and in 2020 she was awarded the highest award from the ISTH as an esteemed researcher. I could go on and embarrass Beverley even more, but I'm going to say just one little final anecdote. Next year, we will be having the ISTH Congress in London. It will be hosted by Beverley. This is the second time we've hosted this Congress in London, and the first time it was hosted by Gus. Beverley, thank you very much.
So thank you very much for those kind words, Steve. And hello to everybody here and those who are dialing in. I'm just waiting. Oh, it's wonderful. I've got help. Fantastic. Okay, so we're going to talk about global awareness of thrombosis and hemostasis. Rather unusual topic, I think, for thrombosis and hemostasis meetings. And I want us to think about the whole point of any research that we do, because we all do scientific research, but it is valueless until we share it, and normally we share it with those who are part of our community. But the most important thing that we have to do is to get it out there to the public, and get it out there to big institutions, all sorts of institutions, probably the biggest, the World Health Organization, so that we can affect change. So that if we know about venous thromboembolism, patients can prevent having it, institutions can put in protocols in hospitals so we don't have clots in hospitals, and if somebody has a clot, then they need to recognise it early to prevent it turning into a problem. So if we think about how we have learnt about thrombosis and hemostasis, it was a slow start. We know that in 400 BC, Hippocrates noticed that the blood of a wounded soldier congealed as it cooled. We've got glorious pictures from Leonardo da Vinci describing the whole venous system. And then we had the insightful comments of Rudolf Virchow back in 1859 describing the main risk factors for venous thromboembolism that we still use today. And then if we look back over the previous century, they started off with some very basic concepts of coagulation. And it was like stamp collecting in the 50s and 60s and 70s. Many laboratories in the UK took part in identifying various factors that take part in coagulation. I think about the labs in Oxford. I know many of the labs in London were doing this. And now we have the glory of amazing technology. We can look at genes. We really are moving into it all. And I can't, giving the Gus Born lecture, not talk about Gus Born, because I've read all about him. What an inspirational person he was. And for me, he sort of demonstrates how one should behave as a scientist. So he was born in 1921 in Germany. His father was Max Born, who got a Nobel Prize for his work on quantum physics. And the family had to leave Germany because of the anti-Semitic intentions of the Nazis, and they went first to Italy and they came to the UK. And Gus qualified as a doctor from Edinburgh University. And he enlisted in the Royal Army Medical Corps and was one of the first to go out to Hiroshima after the atomic bomb, and unfortunately to see the victims dying of radiation poisoning and noticing the severe bleeding and recognizing that it was platelet deficiency that was causing that problem. And that became his lifelong interest. Now, I know he was a professor here, but for me, his glory days were when he was the Van der Velde Professor of Pharmacology at the Royal College of Surgeons, and that was from 1960 to 78, and that's when he had the concept of this very simple platelet aggregometer. For the first time, instead of just looking at platelets, there was a measure of platelet function, published in Nature. Very simple, really simple idea. You're just shining a light through plasma with platelets suspended in it, and you're looking at the density of the plasma. And of course it falls off as the platelets aggregate. And he also noticed that early on there was increased density because of the change in platelet shape. So he ran with that. And then down the corridor, another lab with a whole different concept about the endothelium. So he's working with John Vane. I've noticed coming through here that the John Vane lab exists. I was trying to connect with Gus, and I've got this picture of him with Salvador Moncada, who I met briefly. So I put that picture in there. But in that time, can you imagine what it must have been like in the tea room with the two labs working, one on the endothelium, realizing it wasn't inert, realizing it was producing prostaglandins, and then we've got data coming out of people working in the labs. So Smith and Willis got together and demonstrated the anti-platelet action of aspirin and non-steroidals, which hadn't been known for the 150 years that they'd had aspirin. That's a picture of the lab, and there they are in front of John Hunter. So as Steve mentioned, there he was, creating science, taking it out to the rest of the thrombotic and hemostasis community. This is from the 1979 ISTH held at the Royal Festival Hall, and you can see his name there on the right. And it is a wonderful thing. I feel a little bit connected with Gustav because I am chair of the local organising committee for our meeting in London next year. And progress is moving on for a face-to-face meeting at the Excel Centre. So here we have Gustav, and this is from a programme called Tomorrow's World, which everyone used to watch in the 70s and 80s, which used to show the forefront of science. He's talking now after John Vane has just said, well, of course, the future is prostacyclin, prostaglandins, there will be a tablet, and it'll stop all heart attacks. And he's coming in and
prostacyclin and similar agents which prevent the platelets from forming a thrombus
and I'm going
could.
To just get, I've got another version of this. I've had great help today.
In some cases, patients are delirious or...
No, nearly there.
Prostacyclin and similar agents which prevent the platelets from forming a thrombus could have a future as a drug. Mind you, it's very early days, and it is possible that the mechanism is so much more complicated that even prostacyclin isn't going to take care of it sufficiently well.
So how true he was. Prostacyclin was not the answer to heart attacks, and as we all know, we use many drugs to manage patients.
Prostacyclin and similar...
There we go. So we're moving on now, and we're thinking about how much science was there in the 1980s. And this is my poor old textbook from the 1980s for hematology. 150 pages, hundreds of pages on white cells. How much is actually there about thrombosis and hemostasis? Well, it was a disgrace, really, because there was nothing on deep vein thrombosis. There was very little on traumatic bleeding, postpartum hemorrhage, and you can see the missing place where deep vein thrombosis should have been in the index, because there was no content. So you could argue that thrombosis and hemostasis, we did wonderful things with haemophilia, we had basic understanding of thrombosis, was an academic backwater. And I want to bring you up to date now, and I want to push home how important thrombosis and hemostasis is to keep everybody alive. And we're going to first of all concentrate on the global consequences of bleeding. Now, how do we do this? Well, we look at deaths, and we have this wonderful thing that the WHO do every 2 years. They tell us about the number of people who die, that's about 55 million at the moment, and how they die. And this graph, the x-axis, is increasing age, y is number, and it's colour-coded. So anything red and pink is communicable disease, and also maternal problems. Funny how they've gone in there. Blue is non-communicable disease, and before we had the COVID pandemic, the WHO were really concentrating on non-communicable disease. This is by far the biggest killer, particularly in low and middle income countries. But at the bottom, you can see quite a lot of green. So what is the green? The green is all about trauma. And when we look at global deaths, we've got about 4 million deaths every year due to trauma. If you look in the developing world, if you're under 40, you're more likely to die of trauma than anything else. If you live in the United States, children die most commonly from trauma, and shockingly, the data came out yesterday, the commonest cause of death in pregnancy in the States is homicide, gunshot wounds. So we have this issue, and you can see that the number of deaths from trauma has increased over the years. Road traffic accidents probably account for about half of all the deaths due to trauma. So what happens when you die from trauma? Well, a lot of the patients will end up in hospital, and if we look at why they die, can you believe that 45% of them are dying because they exsanguinate, because they bleed to death? So this is a really big issue that we need to be aware of. And the other big bleeding issue is maternal mortality. Now, we don't really know how many women die in pregnancy every year because we don't have the data. In sub-Saharan Africa, many women deaths are not registered, but we anticipate that there's probably more than 300,000 women dying every year globally. 99% in low and middle income countries, but still we have this issue that when we look at the breakdown of deaths, we have about 40% of them dying from postpartum hemorrhage. They exsanguinate. So think about it. We have a big problem still with bleeding in 2021. Trauma is causing 9% of global deaths. Bleeding is the major preventable cause. Postpartum hemorrhage is causing 1 in 200 deaths. Again, bleeding is the major preventable cause. And for me, the issue around postpartum hemorrhage is we have a crisis. We need to get more work done in this area. There's a woman dying of postpartum hemorrhage every 4 minutes. As I said, most in low and middle income countries. And the consequences of that woman dying are not just that woman dying, it's usually with the third or the fourth or the fifth child. And so the surviving children are more likely to die. We know this. They have poor nutrition or they have reduced schooling because the oldest stays at home to look after the youngest. There's a loss of productivity and maternal health supports, and a country's economic growth are absolutely intertwined. We have a real problem here and we need to highlight it, and that is what we all planned to do. So let's have a look at a unit that has highlighted it, and that's the London School of Tropical Medicine. They have a clinical trials unit, and since I have been working with them in 2005, we have been looking at trying to reduce bleeding in trauma and postpartum hemorrhage with a really simple drug, tranexamic acid. It's a synthetic analogue of lysine, and it's an antifibrinolytic. And we know that if you bleed, you also stimulate clot breakdown, and we just switch off the clot breakdown early on. So they were able to do unbelievable trials. Who had ever done a trial of 20,000 patients with bleeding due to trauma across the world from 274 hospitals in 40 countries? And we also have the woman trial, which published more recently, 20,000 women with postpartum hemorrhage randomized to tranexamic acid versus placebo. Now, the reason for these large numbers is a pragmatic clinical trials, so that they're all having different protocols. But if you just add a question right over the top, you get rid of the variability due to the different protocols. So you will get an answer out. When we look at when they die, we know in trauma they usually die of exsanguination within the first 24 hours. This is from the woman trial, looking at when women died in the study. 5% of the women died of postpartum hemorrhage in the study. They were dying in the hours after randomization, so most of the deaths were due to bleeding within the first 24 hours. And to cut a really long story short, this is the summary of those huge trials. If you gave tranexamic acid and you gave it within 3 hours of either trauma or delivery, on this forest plot you can see that tranexamic acid reduces death. If you gave it after 3 hours, you had no benefit and the possibility of harm. So if you can give TXA to patients who are bleeding with trauma, you have the potential for really reducing mortality. And this paper estimated that if you gave it to everyone as soon as possible after trauma, you could save 128,000 lives a year. So the consequences of that work, we won the first BMJ research paper of the year, but more importantly, TXA is incorporated into the management of postpartum hemorrhage and traumatic bleeding across the world, and it's in paramedic packs. If you have an accident, the paramedic will have it in his pack. If you're bleeding, you will get it. Work with the British military, they have it in their helicopters, and the doctors will have it if they come out to seeing you. The problems that we have are that in low-income countries, they don't have enough money to be able to buy it. And we're talking about a drug that only costs $5. So let's look at the other side of the coin, the global effects of thrombosis. Let's get back to the WHO data. You can see that within the blue, within the non-communicable disease, we have some darker blue, and that is highlighting some of the thrombotic disease. And when we look at the global burden of thrombosis, we know from the WHO data in 1990 that 1 in 5 deaths was due to thrombosis. If we think about myocardial infarction, stroke, and venous thromboembolism, that's gone up to 1 in 4 in 2010. It's going up in low and middle income countries. It's coming down in the developed world. The orphan of those 3 diseases is venous thromboembolism. So not really well covered. It's lost in the data. It's not calculated separately, but various epidemiological studies have estimated high rates of death. So it's the 3rd most common problem with thrombosis, but we're expecting 1 in 1,000 people every year to have a VTE. And what we do know, and we can focus on, is that 60% of people who have a VTE have it during or up to 90 days after a hospital admission. So we can focus there and try to reduce mortality. And the WHO starting to be aware of this. They've done a global estimate that there's probably 10 million hospital-associated VTE cases every year. And it's the number 1 cause of adverse events after admission to hospital. It's the biggest cause of lost disability-adjusted life years, and much bigger problem than hospital-associated infection. But what does the public know about it? Because we have quite a lot of science, a fair number of the professionals know about it, probably not enough, but what did the public know about it? So this is a survey, an Ipsos Reid survey of patients or people in 9 countries across the globe. We did it as part of the World Thrombosis Day team in 2015. If you look on the left, you can see, if you ask people what do you know about or have you heard about or what is breast cancer, we're talking about most people, 80% of people knowing about breast cancer, stroke, heart attack, high blood pressure. But when you ask them, well, what is thrombosis? 2/3 of them might know the answer. And then globally, if you ask them, well, what is a deep vein thrombosis or pulmonary embolism? About half will know. And then if you ask them, this is the graph on the right, what are the causes of venous thromboembolism? You can see most don't know. They don't know that hospital stay is a major problem. Only 25% knew that. They don't know that estrogens are a major cause and that pregnancy is a major cause, as is cancer. So we have an issue here. So really, I first got into this game when I founded what we called Lifeblood, the Thrombosis Charity, which is now called Thrombosis UK, in 2002. And we have worked on public awareness of venous thromboembolism since that time. We are now the patient voice for VTE in the UK. We're now a medium-sized charity. And if you look at the stats, we've done surveys of the British population. Even in that international survey, the Brits knew far more about VTE than anyone else. So we support patients. We have a National Thrombosis Week, but we also campaign to improve care, and we were Charity of the Year in 2010. And we campaigned about hospital-associated VTE. we calculated there probably were 25,000 preventable deaths every year, and that we needed to have some way forward to make sure that when we had patients admitted to hospital, they would be assessed for their risk and receive appropriate thromboprophylaxis. And of course, most people, when they come into hospital, they don't really think about that. It needs to come from the medics, that they just automatically risk assess them. And we know that clots are actually more common in medical patients. You'd think they'd be more common in surgical patients, but in the UK, 70% of our admissions are medical, by which I mean they're generally unwell, not coming in for surgery. And orthopedic patients are also at risk, even though these days we do a lot of work mobilising people after surgery. We too had commissioned Mori polls, so we knew that people knew about DVT. At that time, more than 50% knew about DVT. This was from a lot of publicity about travellers' thrombosis. There was a House of Lords session on travellers' thrombosis, and they advised everyone to take aspirin. And to this day, one of the commonest questions I'm asked is, should I take an aspirin before I step on an aeroplane? And the answer has to be no, 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 because you take an aspirin, you increase your bleeding risk, and you don't do much about reducing your risk of thrombosis. So we have worked, and we knew, looking globally, people should be giving thromboprophylaxis. We know thromboprophylaxis, which is giving small doses of anticoagulant, will reduce your risk of VTE. This was a snapshot audit across 358 hospitals in 32 countries in 2008 from Andy Cohen, who I work with. They showed that half of the inpatients in hospital were at risk of VTE, but in the UK, only 58% of the surgical and 40% of the medical patients received thromboprophylaxis. So we needed to do something. There was a lot of work. We managed at the time, myself and AJ Kakar, to meet with Richard Taylor MP, who was chair of the Health Select Committee. We got an urgent Health Select Committee. They had a hearing, and they asked, why is it that we have such a high death rate in the UK from hospital-associated VTE? And the report came out, a systematic failure. We have to get institutions involved in delivering care. The health professionals weren't aware. Nobody was teaching the undergraduates. There wasn't a systematic approach. There no longer were post-mortems happening. Quite often, as a junior doctor, I might go down and see a post-mortem, and you might expect if someone died suddenly in hospital that they died from something, and almost always they were dying from pulmonary emboli. And we have this problem with deep vein thrombosis. 80% are clinically silent, and if you have a pulmonary embolism, many patients will die of it with the first event. So the other problem was the healthcare professionals said, well, we don't see it. They wouldn't expect to see it. It's silent. And the other issue is that hospital admission stays had reduced considerably. So over 50 years, average length of stay might have been 10 days now. If you come in as a surgical patient, you're in for 1 or 2 days. The average deep vein thrombosis is day 7 after your surgery, and your average pulmonary embolism is day 21. You're long out of hospital, and the GP may notice that the patient is short of breath, or might notice that they've got a bit of chest pain, but not think about pulmonary emboli and put myocardial infarction on any death certificate. So cases were missed. So the House of Commons Health Committee said we have to introduce a system into UK hospitals. And so we campaigned for many years to get this done. We had lots of high points and low points. Tony Blair used to talk about it in Parliament, and then finally in 2010 we got implementation. Hospitals had to do VT risk assessment, and if they didn't, they will lose money. This is called a sequin system, and the money they would lose was considerable. So this concentrates the minds of the managers hugely, and systems were introduced into all the hospitals. And a consequence of that, which is an ongoing issue, is that the death rates of people leaving hospitals has dropped dramatically. So we've had a 15% fall in death rates due to venous thromboembolism after patients are discharged from hospital. And so we've got a system in place, all the institutions involved, it's punitive, so they have to get on with it, it's embedded in healthcare, and we have success in reducing death. And to be fair, NHS England by far rules the world as far as this is concerned, because no one else has got such a pragmatic system in place. So part of the charity is to also get articles into papers, to get articles onto the web, to have a good website, to now be part of Twitter, Facebook, have Facebook groups, anything we can do to increase awareness and education of the public. And we have to work with the media. We have to work with the media these days. It's just a necessity. We have to keep reselling things that we think don't need to be resold. The facts are compelling, but you have to keep reselling to the media. They get bored, they want a human interest story. We have an Excel spreadsheet of patients who will talk on different issues. Sometimes you might get a phone call from a journalist wanting an instant story. I had one yesterday. We had to reply and respond to an angle they had, and you just have to do it. And you have to constantly think of a fresh tangent to your story, and remember that what's said today is tomorrow's fish and chips wrapping. And of course, if you've got a celebrity, then they will take the story. So I've told you about Thrombosis UK, our plans to keep going, increasing awareness. And now let's move on globally. We've got World Thrombosis Day. Now this is a movement that was started in 2014, and the whole aim is really to reproduce what we've done in Thrombosis UK, to take out all of the stuff that we have around thrombosis, to get people to engage and learn the simple facts that we have, and also to work with big organisations so that we can affect systematic change. And of course, that is the World Health Organization. They are planning to reduce premature deaths by non-communicable disease by 25% by 2025. We have to help them with that by reducing deaths due to VTE. So this is really what we need to keep doing again and again, and this is what we need to be doing in bleeding. We haven't even started there. So we have to highlight the burden of the disease, increase awareness, empower individuals to tell their stories so that they will influence others, galvanize organizations at a national and global level, and to advocate systems of care so that when someone says, okay, I think maybe this hospital needs to improve its VTE prevention, that we have a system that we can offer them. So we have World Thrombosis Day, which is Virchow's birthday, which is October 13th every year, and we have grown very, very quickly as an organisation. There we have the Niagara Falls being lit up by World Thrombosis Day colours, and hospitals across the world and individuals will do things for World Thrombosis Day. The numbers I can't cope with anymore. So this is last year where we got 5.2 billion contacts through social media and also through multiple articles and being interviewed on radio and TV. And this just summarises the social media. It's just extraordinary what you can do if you set out with intent. So these are some of the things that we did this year on social media. So we got people to record videos saying what they felt about World Thrombosis Day, why was VTE important. We did Facebook Live and answered questions to anybody who wanted to ask them about thrombosis. We had an educational webinar with the CDC, and then we had a Twitter chat where you're delivering information over Twitter. And this was this year's slogan, or your eyes opened the signs, symptoms and risk factors of thrombosis. The other side is that we have to work with the World Health Organization. The vision is that one day, if you walk into any hospital in the world, you will automatically, as you do in NHS England, get risk assessed for venous thromboembolism and get appropriate blood thinners or intermittent pneumatic compression as you need it. And it's very hard work. We've been trying to engage now with World Health Organization for about 5 years. We are slowly moving forward. They know they've got to do it. It's just they have been delayed by COVID and so many other things. And they aren't built well. They don't seem to be accountable to anybody. So we have to work very hard to persuade them that VT risk assessment and prevention is so very important. But of course, the world has changed, and we have had and we are having COVID-19. And if we think about this being a new disease and how much thrombosis was part of those who were in hospital who had COVID pneumonia and they ended up in intensive care. And we have really high rates of deep vein thrombosis and pulmonary embolism in them, because what does COVID do? It makes your blood really sticky. It makes the lining of the vessels, your endothelium, really switched on, and you're immobilizing patients in critical care. And then we also discovered very quickly there's more going on. There were 2 pathologies in the lungs. We had also tiny microvascular thrombosis in the areas of really high inflammation that we see in COVID pneumonia. And this had been known about before. This was described in 2013 by a group of thrombosis experts, but it wasn't widely known. So we have learned all of this. And it's a fundamental thing that when we look at thrombosis, it's the end point of inflammation. So if you have a lot of inflammation somewhere, wherever in the body, eventually the cytokines will cause microvascular thrombosis, i.e. immunothrombosis. And then on top of all that, one of the problems with COVID pneumonia is that the patients are very short of oxygen, hypoxic, and hypoxia drives thrombosis as well. So we learnt very, very quickly what was going on, but how do we manage it? We were all guessing or using evidence base from other diseases to start with to know how we try and prevent it. And there was a real thirst for knowledge from healthcare professionals. So last April, right at the beginning of the pandemic for us, Marcel Levy and I opened the first of a series of webinars run by the ISTH. We had 4,000 attending and 16,000 viewed it later. So this is all thrombosis professionals avid to learn what to do. And the first guidance on the management of coagulopathy and thrombosis came from the ISTH. But what about the public? Well, lot of media interest in thrombosis, huge media interest, and so they were always phoning either Thrombosis UK or World Thrombosis Day, wanting a quote, wanting someone to talk, and it was really important to get the message out there. I actually spoke on the Today programme very early on. I think it must have been last April. And David Hare, the playwright, was listening. And I used the word sticky blood, because that's really what is going on in lay terms. And he had COVID at that time, and he used what I'd said in a play he wrote about his experience of COVID and also having a real go at our government, and it's called Beat the Devil. And it's now turned into a theatre production, which Ralph Fiennes has led in, and I had the good fortune to meet him, and it's actually now a film. It was screened last week, and I have a little bit...
In some cases, patients are delirious or suffer...
A little bit from the play, because they describe what's happening in severe COVID beautifully. Oh no, I'm going to have to... Could I have a bit of help? Yes, thank you very much.
In some cases, patients are delirious or suffering inflammation of the brain.
COVID.
But all this is less pervasive than the blood clotting. Beverley Hunt, a professor of thrombosis, no, I didn't know there was such a thing, at King's College London, is telling us that she's noticed an awful lot of sticky blood. In fact, she is seeing the stickiest blood of her career. And when you've got sticky blood, she says, you're much more prone to having deep vein thrombosis and pulmonary embolism, which is when one of the deep vein thromboses travels around and blocks the blood supply to the lungs, which adds to the problem of pneumonia. Professor Hunt uses an unexpected phrase. It's almost medieval in what we're seeing.
So I'm showing you that because to have someone describe the effects of COVID like that in a play is what we want, because how else are the public going to learn about all of the different aspects of COVID and thrombosis? How neat was the description of DVT and PE, unless it becomes into common parlance, unless we go wherever we go and people just talk about it. It was a very wonderful thing to see. Now I have lost. So that's COVID, and now we have 2021 and we're being vaccinated. And as Steve said, one of the less kind features of vaccination with the AstraZeneca vaccine is that we have seen vaccine-induced immune thrombocytopenia and thrombosis. And the public have really engaged with this. They are scared of this. They are crawling around the internet trying to find more information. I can't tell you how many times we have had emails, phone calls from people who are terrified. Not a good way to learn about thrombosis, but I suppose the positive thing is that they are learning. So COVID-19 has really brought thrombosis to the forefront. We have had to deal with the most prothrombotic state we've ever seen. In viral pneumonias, we've struggled and now know how to manage these patients to reduce their risk. What I haven't talked about is that lockdown has increased immobility and weight gain. We've seen a lot of people with clots from sitting still for too much. We've had the vaccine, and now we have post-COVID syndrome where people are talking about microclots. But what has happened is that the general public are much more aware of thrombosis. So if we go back to my original diagram about scientific discovery and how things happen, how can we conclude? Well, I would say that thrombosis is in a pretty good way. We have very good systems in place. We have excellent science now. We have amazing professional understanding and public awareness about myocardial infarction and stroke. We still have work to do so people understand the signs and symptoms of venous thromboembolism, and we could really prevent a lot of deaths if we got the WHO to mandate thromboprophylaxis globally. Where we struggle is in bleeding. We don't have the science behind postpartum hemorrhage. Nobody has ever done a study following the sequential changes of coagulation when a woman has postpartum hemorrhage. We don't fully understand how to manage it. Most of this is happening in low and middle income countries where we need to get safe and effective and cheap drugs to them, and we don't have the studies. So we need urgent attention to this area, and one of the ways to do this is for me to stand up and tell you about how difficult things are there. So that's it. Thank you very much for listening. Thank you to all the people that gave me a hand in my presentation, especially in the last half an hour. Thank you very much.
Absolutely fantastic, Beverley. An amazing lecture, and really, I use the word inspiring for Gus Born. I'm happy to use it again. I think it's incredible what you've achieved. I know there's no questions on the Q&A because it's just a practice up there to see if there were any coming. Has anybody got any questions? If not, I think one of the last things that have appeared in the last 18 months is just the sheer excellence of science in the UK. There's no two ways about that. You used the word world leading for awareness of thrombosis, and I think that's really very good. I think a lot of this underpinning came from some fantastic thrombosis and hemostasis researchers, of whom Gus Born is one, John Vane, Rosemary Biggs. It's a most remarkable period in the UK. I've just written a history of thrombosis and hemostasis for the British Heart Foundation, and it really begins to show how we are so leading. I think where we have failed is to really make that apparent to the public. And I'm so pleased that you raised it. I have a slight joke about Gus Born's contributions, both being so successful and holding us back slightly, a bit tongue-in-cheek. The method we use to study platelet activation today, Born aggregometry, was in 1962. And we still use it today in my laboratory. And I don't think I like telling people that's our state-of-the-art technique from Gus Born. But it is, and it's because of the methodology in which he did underpinning work. The question I'd like to ask is, how do we really do this for bleeding? I'm so pleased that you raised this on bleeding. It is life-threatening in a relatively small number of people, but quality of life, particularly for women, and it's just such an under-recognised area, and how do we go forward and change? And that's what you've been talking about. But I think it's such an under-recognised area. So thank you for raising it, and I've left you a sort of open-ended question there.
You want me to answer it?
Yeah, well, you've answered it anyway,
okay.
But I think I wanted to re-emphasise that point.
What can I do?
What can we do?
What can you do? What can you do? I think in the UK we are blessed with a very good scientific community, just as you said, and we need to get research agencies to have calls out to so that we can get funding, so we can just look at the basics of postpartum hemorrhage as we see it in the UK. We see postpartum hemorrhage, but women don't die because we offer them a hysterectomy or some procedure like that. We've got surgical approaches, but we could follow women as they bleed out. We could discover quite what are the main changes as patients bleed out and then try and counteract them with the appropriate drugs. It's going to be a long haul, but we need to start.
So I'm just going to, please.
Hi, Beverley, thank you very much. That was really inspiring, a lecture, and someone who my whole lifelong mentor was Gus Born. I wanted to tell you that what you're doing is amazing and you're communicating it with people. But I want, just because Steve was talking about platelet born aggregometer, but I was an undergraduate student at King's, 1982, it's a long time ago, and he took me to see, he was filming the mesenteric artery being bombarded with a laser, and then you saw platelets come together and aggregate. So that's when I said to him, I want to do this. And there's a whole story. But going back to what postpartum hemorrhage you talked about, do you think it's because, as you said, the cost, I work on preeclampsia, the cost of that is so insignificant for biotech and pharma, and I'm running a company on this, is that the reason why no one's bothered to tackle postpartum hemorrhage? Because it's mainly in the third world countries.
It's a hidden issue, and I think that many of the women who bleed to death are very anemic to start with. So it's usually the third or fourth child, the uterus doesn't contract down, they're starting off with a hemoglobin of 70 or 80, their bleeding time is prolonged, they lose half a litre, which would be fine if you were here and your hemoglobin was 130, and it just carries on because they've got the prolonged bleeding time. So there are many issues around it, but logging it is an issue. We can all have different approaches to it. I don't know, some people go out to the third world and they go and help in obstetric units. We need better blood transfusions there. We need drugs made available. There are so many ways in.
So why is WHO not engaging when it's... They have done a lot of work and guidance on uterotonics and trying to make them available, so the WHO essential drugs. But it's not enough. We need, the women need antenatal care, they're not getting it. Many women are not giving birth in an institution, they just got a local midwife, they don't have access to a line, they don't have access to blood. We've got a long way to go. We've still got issues here with postpartum hemorrhage. We still don't know well enough how to manage it. We don't know, should we, when we have a woman with postpartum hemorrhage, give her a lot of fresh frozen plasma as we do in trauma, or should we just give her red cells and some fibrinogen concentrate? We don't know because no one's doing any trials.
I think we're going to have to finish there because because of time. I think there are many other questions I can see. Again, Beverley, I'd like to thank you enormously. I'm going to hand over to Rod to say a few words.
Thank you very much, Steve. Gus was jointly responsible for giving me my first job in science in the 1960s. So it's a particular pleasure for me to make two presentations tonight on behalf of the Born family through Carey Born, who's with us at the back of the hall. So the first one is to our lecturer tonight. So Beverley, thank you for a super lecture. And this is a present from the Born family.
Oh,
and there's even an expensive carrier bag for you to carry it around with. Okay. Thank you very much indeed.
And secondly, again, a really nice gift from the Born family, as I say, coming through Carey tonight. And that is a portrait, which I'm going to unveil in a minute, which will be hung in the Institute together with a bronze plaque commemorating Gus's time here. And I'm going to try and unveil it without pulling it over. So, there we go. Obviously, we'll hang it near a nearby telephone so he can...